Welcome. I hope you're in for something completely different, because when I looked at the program and I looked at my title, I was thinking, this is a bit out of the scheme of the rest of the program. So I hope you're in for something that's different. I'm from Denmark. I'm an infection control nurse. I've been in the field for 26 years. I hold a master's degree within education, and I've always been extremely interested in how guidelines can provide behavior, how they can regulate, and that strong belief we have in that. I'm also of the conviction that IPC stands in the intersection of the three sciences, the natural science, the social science, and the humanities. And when I did my PhD, it was with that starting point, and that is what I'm going to present for you today. So, scenic is the mother of all surveillance systems. This is what we strongly believe in within infection prevention and control, that surveillance gives us the data and shows us where to go when we put in the preventive actions. Haley showed this way back in the multi-center studies, and what all surveillance systems are accomplishing is that we do the surveillance, we present the data, and we think this is it. What Haley also said in this was that data was good because that could break down the complacency and denial, which many clinicians would have, and by this we could persuade them into doing the right things. This is not what most of the articles are describing. Most of the articles describe how to design a surveillance system and how to put it up, etc. But what he also said, Haley, which is not being referred to or being quoted in many articles later on, is that many of these data, many of these reports just ended up on a churchyard on the administrators' desks, not being used for anything, but they've been produced. And maybe it was because that the meaningful was hard to see for the ones that received the data. So the data produced voluminous reports, but it failed to give a meaningful report back to the clinicians, so you actually could start another behavior. So this tricked me, because are we doing a lot of work that's actually not being used? Can we do this differently? And what is it that people don't understand or maybe misinterpret in the data? So what happens when we present these data? So the other thing was that in Denmark, we just initiated a new national surveillance system, which was automated. So I was like, okay, when you read the articles, there's a great focus on data-driven healthcare. That's a mantra, it's a big, big thing. And all the articles were on surveillance systems validity, sensitivity, and technical design. And there was less focus on how do you read the data, how do you give the feedback, and what is actually the effect of this feedback? Can we see a reduction in the nosocomial infections? And then there are also articles saying that this technology marching into the clinical practice actually does something to the clinical assessment. It does something to the clinician's way of looking at what's happening out in the clinic. And as I said, we went from the prevalence, which was a handhold thing, to a technical automated surveillance system instead of. And when I did my prevalence studies, I was so touched by the patients behind the journals. The suffering, the many days they were admitted, etc., which made my work at my administrative desk much more actual, much more touching. I wanted to make guidelines that could actually move people out there. So I was thinking, what happens when you go from the physical contact into something that you have not been involved in, but you're just reading data that's been automatically taken in? So what are the consequences in this? And if you're not touched by the data, how can you give a meaningful report back again? Because this is something about touching people so they actually move. So my overall question was actually, with the automatic surveillance system, can you actually see the patient behind the number? Because we must never forget that there's a person behind all these data that we collect. So that was one of the questions, and the other one was, is it the actual data? Is it the number that drives the action, or it's something completely different? So my question was, and I was inspired by Austin and his speech acts, and he says how to do things with words, how you can impress people, how you can influence people with words. So I was like, maybe I should look at how do you do things with numbers? Can you actually influence people with that? So my question was, how does the reader, and the reader, that's you, actually make meaning of the data? What are their knowledges? What are their knowledge and what is their attitude to hospital-acquired infections? And how does meaning making influence the recommended guidance action, that be in dialogue or in written papers? And when and where is this reading actually taking place? So I dived into a lot of theories that I've never seen before because I wanted to analyze the discourses that were out there, because the way we talk about the things create the problem, it minimizes it, it makes it into nothing, it makes it into a great thing. The way we talk about the things influence the way that we act upon them. So I wanted to do this discourse analytical framework, and I used practice theory and theory on resematization as a theoretical basis. And I will not tell you more about that, because that will make you fall asleep instantly. Okay, so we move on, but this is, think about how you talk about the things. I mean, that's a simple way. I went through all the 5 regions in Denmark. I did questionnaires, semi-structured interviews. I was actually sitting side by side with my colleagues at the computer saying, okay, when you read the data, tell me what you see. Try to put words in what you see when you look at the data now. And I was at all the meetings where they discussed the data, where they discussed the preventive strategies, etc. And all the time I was listening after, how do they talk about the numbers? The worst thing was actually that all these were my colleagues. So getting into the office, and I've been smiling a lot, making myself presentable and being able to be there. One of the theories I used is the theory of social construction. And this theory actually looks at that everything influences everything. In the social and the natural world, the theory about the butterfly that flips its wings and then something else happens in the other side of the world, that's exactly the same thing here. Infection prevention and control is influenced of all the discourses that goes around in our country, in our world. So right now, the big discourses are about sustainability, right? That influences IPC. We had benchmarking, that influenced IPC. We had savior in cost, that influences IPC. So we are not an island all by ourselves. There are lots of other things that have different discourses, different ways of talking about IPC and talking about the numbers. So that was one of the theories I used. And HYPA is our surveillance system, and I wanted to look at how does all these discourses actually influence the way that we interpret the data from here. So some of the findings I'm going to show for you here has this outcome on the reading and meaning making. I looked at something called membership, and actually I found 2 superior membership, actually founded by a new partner coming into infection prevention and control. And these 2 superior memberships have their own specific associated actions when they look at nosocomial infections. One of them is this an adverse patient safety event or is it a complication? I'm going to show you more about that. Then there are data as an actant, data as a person almost in this one. And benchmarking and priority of resources influence the way that we look at the data. And data can also be an entry ticket, a way to get into the administrator's office, because now I have something to show you, something you have to react upon. It can also be a weapon, something that you go out and you present people and you lift your finger and you say the numbers are way too high, so you can use them as threatening your clinicians also. But altogether, they affect the interaction order, the way that you talk, the way that you work together out in the hospital. Then there is a whole area around resemiotization. How do you interpret and how do you translate these data into something that people can actually understand? So there was I heard a lot of narratives, I heard a lot of use of metaphors, and I will show you some multimodal social semiotic meaning making, but I'll also talk about something about this mental number line that you maybe not know that you have inside your head, but you do have that. You have a number line in there. And the distributed cognition. So the first conclusion I came to was that this is important, because what a clinician does and expresses in his reading and feedback is conditioned and limited by the context, the world around it, and it's limited by his own context, his own history, his own experience, his own risk assessment. That is the way he expresses what he reads. Does this hold a lot of power? Do you hold a lot of power when you do this? Yes, you do. So we have had new partners within this reading, right, or within hospital in the total, because we had the patient safety. And patient safety is something that looks at adverse events, right? Things that could be prevented. So 2 of my interviews, their statements are here. The first one, when I asked her, what do you think about nosocomial infections? And she said, this is simply unacceptable. It's morally reprehensible. It is something we just shouldn't do at all. The other one said, well, if you didn't do anything, I mean, hospitals today are dangerous places because a lot of things are done to patients. Well, we're actually exposing patients to a considerable risk. It's actually in treating them as well. This is 2 different approaches to infections. The one says that this is not acceptable. The other one saying that this is a complication. This is actually what we tell the patients before they go through surgery. We tell them there's a risk of an infection. The patient looks and says, okay, I accept it. So this is 2 different approaches. The latter is the old approach, where we call it complication. The new one is caused by the discourse by patient safety, where we call it adverse events. Can all infections be prevented? No. So already this mixes up the interactions between the clinicians, all depending on which approach you have to prevention in this one. And this will form your communication. So it disturbs the interaction order, and it disturbs the risk assessment. And by this, if you think this is a complication, then you will go forward as soon as you think this is too much. If you think it's an adverse event, you will go for every single situation. And that's the difference when you go out and communicate about it. Do you follow me? That's nice. In patient safety and in the quality movement also, we're talking about quality within infection control. And one of the ways to steer through that is by benchmarking. Benchmarking is a very social thing. We benchmark ourselves up to others and how good we are, how much money we make, what kind of dresses we use. Benchmarking is a social thing. But benchmarking within IPC, I could see that that wouldn't not necessarily always be good for the patient, but it would be something how good we think we are compared to the other hospitals. Not always reconsidering that, is this necessarily also good for the patient, or is this just because we want to be nice, we want to be the good guys in the front of the newspaper? The first one says that, but I would say that we can be pleased that there's a decrease after all, but then I would go in and compare this with how it looks at the other hospital, and they're always competing. They're stealing each other's personnel, etc. They're always competing. And then I would look at the natural level, and then I would probably find that we are at the high end, and we're too proud for that. We have a standard that is higher. We want to be the best. Okay, then I asked his colleague, and I said, this is about being the best. What do you think about that? Yes, yes, but it's also because we are the highest, or compared to other hospitals in the region. And I said, so what happened if you'd been number 3? And again, remember, there's a patient behind the number. So what if you're number 3 in the benchmarking? Would you then do something about it? Well, that wasn't where the effort should have been. But again, it's also a prioritization in relation to our efforts, right? So you go in and prioritize according to where you can see that there are some problems. So again, you navigate between being the best compared to the other ones, and then after that, you navigate in looking at what is best for the patients. Because you might have a high number, but it might be more serious with a low number, as I will show you afterwards, or depending on what kind of disease that you have. So after interviewing people like this, I was like, okay, people have some sense of a size of the number. So we have some numbers that we think are high. You know, right now they're bombing in Ukraine. We were terrified when there were 20 people who died. Now people die in hundreds. And the ads in the paper get smaller and smaller because we get used to the numbers. So that mental number line we have varies to the context and the experience. And this is serious, according to our patients, because for them, it's always serious. For us, it might just be a number and something we've seen before, and this is normal, and this is what we always have. Or you will meet clinicians saying, oh, these kind of patients always gets infection. And this always is actually limiting your preventive measures because things get normal, right? So you have a mental sensation of big and small numbers. And you have a mental number line where you kind of put this spatial representation of the numerical values, and they're applied into the cognitive actions that gives us our senses of numbers. So there will be numbers, there will be sizes of numbers that will make you react. And there will be smaller numbers that will make you think, no, this is not worth it, like she said before. But still, remember, there's a patient behind this. So this mental number line is created by your experience. You get pictures inside your head of this number, and it's also closely intervening with your risk experience. How many can we bear to have at our hospital before we think this is critical? And one of my interviews said, well, we had 400 incidences of urinary tract infections. Now we have made preventive measures, and now we're down to 200. And I was like, but 200 is still a lot, isn't it? Yeah, but it's half of the other, yeah, but it's still a lot, right? Yeah, okay. And then there was another nurse saying, right now we have 100 urinary tract infections at our hospital. Our administrators think that is a high number. I know that I have 5 sternal infections up at the intensive ward, but I cannot get resources to do that because the number is small. And now I look at you. What is the worst for the patients to have? A urinary tract infection or a sternal infection? Definitely a sternal infection. It's extremely difficult to breathe if you don't have a sternum, right? But the number was the one that decided where the intervention was going to be, because he could only see the big number. He couldn't see the consequences. And that was what I said before, that the meaning of the data always must be in the context. What are the consequences of this? So from this, you can see that you need to know to be able to see the consequences. And you need to have the picture in your head. A small mouse will always, or a big mouse will always be smaller than a small elephant, right? Because you know that, because you've seen an elephant, you've seen a mouse, so nobody can trick you, right? But if you don't know anything about infections, then you can be fooled, right, by the number. So you need to know to be able to interpret the number. So in this interpretation of data, you both have to have a sense of numeracy and a sense of language. Okay, so standing on this, and I'm asking you, is it for everybody to read data from surveillance systems and communicating it meaningfully back to the clinicians? No? It is difficult. Is it something that you just point at one at the morning coffee table, okay, you do it today, or it's something that's actually a specialist task? Exactly. So no, not everybody can read data. This is one of my colleagues, and we were looking at, because the administrations had been all up in the red because they had high numbers of Clostridium difficile, and it was on the front page of the newspaper, and what can we do? And the numbers landed on his desk, and he looked at it, and he was, well, this is not because we have high numbers. This is because we changed laboratories, and we do different tests now. So as he said, you really need to know a lot about the algorithm, right down to the laboratory, to be able to analyze data right. And now that's my opinion, that's the laboratory angle. But what happens in the organization? What kind of samples we get? How many samples we get? There are so many variables that are so hard to figure out before we can get to whether there is anything in the real world that changes. And like I said, here they changed laboratory, they changed test method, so suddenly they found a whole lot more than they had before. But you need to know that. You need to be a wise clinical microbiologist to be able to interpret that. So actually, to be able to read a surveillance system, you must be able, you must have the knowledge of how is the algorithm constructed? How do we get the data in? How are they processed? And how do we present them? And you must be able to, be a bit critical, put your head on the side and say, can this be true? This is so different from last month. Can this be true, or do we have to dive into it? And you have to know the context of the algorithm. And then you also always have to be aware that discontinuity in data, because it's vacation, because the system broke down, etc., can cause conflicts and can give you others. During COVID, we changed the diagnostics. During COVID, we changed the diagnosis. During COVID, we changed the case description, right? And it all mingled up our data. And that's what happens. So, but some are really, really genius in presenting. And now this is Danish, but this is one of my colleagues. And she made this graph. And she says, when I go up to the administrative level, they are absolutely blank. They don't know what I'm talking about. Some of them are interested in data, and some of them are just interested in knowing whether it changed or not. So what she does, I'm a former teacher, I can shout at you. What she did was she said, okay, this is our goal. This is the red line. This is our second goal. This is our primary goal. So she also uses colors. Green is for go, red is for we're not there yet. This is actually the one showing what is happening. And then for the ones that just don't understand graphics or numbers, then she has this one up here. And it says it's unchanged. Nothing happened since last time. And she says most of the administrators, they look at that one. They're not interested in this. They're just interested in, has it changed since the last time? So also, presenting your numbers is depending on what group you're presenting to. Some will love data, some will rather see a graph, some will just know what are we going to do about it. So you cannot just take one slide and use it for all the groups at the hospital. You have to differentiate it if you want to go through, if you want to make it meaningful for the persons out there. So, to read a number is like doing a clinical assessment. It takes experience, it takes knowledge, it also takes this tacit knowledge, this feeling of these numbers are not really true. And it's something that requires that you can both talk about it in a meaningful way and that you can compare the numbers, like I said before, numeracy and language in this one. And you have to have insight in the context, which means that you have to get out of the office and into the clinical practice and see, do these data that I have on my desk, do they actually reflect the clinical practice? Or do we have to change the algorithm? Right now, we have a huge challenge in Denmark because people are going back and forth between hospital and home. When I was a young nurse, you were in for 12 days for a hip replacement. Today, you're lucky if you're in for 6 hours and then you're back, which means that we don't see the infections, right? Because we don't count them anymore. Because nosocomial infections are 48 hours, right? But the patients are way out of the hospital before the 48 hours. So our algorithm actually doesn't reflect the clinical practice anymore. So we have to look at, with this transition that the hospital is in, and if we still believe that data is going to drive action, we have to look at both the construction of the algorithm and we have to look at what kind of language we use when we report the data back again. So data is something that we construct, it's something that we negotiate, and it's something we develop through dialogue. If you keep on saying, oh, these numbers are small, then people will say, okay, then we won't do anything about it. But if you go out and say these numbers are too high, then people will react. So to choose the best action in this one is both to do it ethically, professionally, and economically. And don't forget that we have novices and experts in our clinical practice. There will be some that can reflect on this one, see the situation, and there will be others that are saying, I don't get this. So again, construct your dialogue, do it exactly so it fits into the group that you want to reach. So what I found was that my colleagues are the same age as me. We're old, we're gray, we're experienced, we're a bit tired in between, but we're experienced. So they see the same things as I do. My concern is, what do the young doctors and young nurses that only see the patients for a short while, can they make the narrative? Can they see the patients through the hospitals? Do they actually have the experience to be able to read these data correctly? So, and also that we have to be able to do these good stories, be good narrators, and then also think in the two memberships about the adverse events and the complications, because that influences our risk assessment. So reading and feedback is a complex practice. It's not for everybody. And the linguistic translation of the number affects the scaling of the reading, and it affects the preventive intervention. So reading the number is a mental competence, but constructing the meaning of the number is a social act translated into language. So reading the surveillance data, is that something you do by yourself? No. That is always something that you discuss with your colleague. So you get different point of views on this one. So you get different point of risk assessment. So you get different mental number lines involved in this one. So you actually have a reflection on, is this number high? Is it too high? Is it okay? And whenever you say a number of an infections are okay, then please remember what the Danish lady said. There's a patient behind that number. And that patient is relying on our professionality to prevent and to help and to care. So we need to talk about the numbers and make that meaning together.